and good evening, everyone. Welcome to our 33rd Growers Virtual Seminar. Growers Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I'm your host, Adam Getachew. I'm the co-founder and CTO at Ethiopia, and it's a huge pleasure for us to have Dr. Abnet Ayalew here with us again. And she's going to give us a lecture on the medical ethics topic. For those of you who didn't know Dr. Abnet, she has already given a previous virtual seminar for us on the topic of medical error and negligence. I think two or one month before. So for those of you who don't know her, Dr. Abnet is an assistant professor of forensics medicine and toxicology, currently working at St. Paul Millennium Medical College.
So thank you, Adam. It was a good introduction. So I hope we have met before with most of you on the medical error and negligence session. So for that to be a complete picture, to give you a complete picture, I believe medical ethics is the background, and it's worth discussing so that the health professional would know what's ethical wrong and right and what's negligence. So that's why I opted to do this medical ethics session, as I promised I would do in the first session of medical error and negligence. So I would also like to extend my gratitude to Blue Health Ethiopia for offering this kinds of podium. It's a lot of work that they do, honestly, so I would really like to appreciate them. The medical ethics topic is a vast one, so I would just start with the presentation right away. I don't want to take long with the introduction. So everyone will come on board. The progress would be as already introduced by Adam. So I'll just go forward. Some of the slides you might recognize from the previous presentation, but since they are essential and they're easily confused subjects of ethics and morals and error and negligence. So I have brought some of the slides again from the previous session. So they would be discussed as follows. So what is ethics basically? It's just the standard of rules of conduct that govern natural disposition in human beings. Morals, on the other hand, is just about what's good or bad regarding a human character or behavior. So moral usually is currently narrowed mainly to matters of behavior, social and professional behaviors, such as sexual or social behaviors, whereas ethics is something that a group of professionals gather up and decide on to create what's beneficial to the core of that group, how the services should go, what's protective of the medical practitioner, and all. So ethics is more of intellectually derived rules of conduct by a specific group or profession. And ethics is not something dogmatic or something statutory. Those people, the group of professionals, could every time come together and revise based on the current developments. So what once was thought to be an ethical act could be later on included as an ethical one. And there are also a lot of subjects that are joining the code of ethics, like in current days, most medical ethics codes have included subjects of euthanasia, subjects of tissue retention, transplant codes, and all. So in the earlier days, these topics were thought to be fancy and far-fetched, but currently these topics are going to be are included in most codes of conduct, codes of ethics. So ethics, just to explain that, ethics is something that evolves through time, that could change, that is subject for discussion and modification through time. So the code of ethics generally retains the moral guidelines. And what code of ethics usually keep in mind is what's accepted as morals of the society. Also, a code of ethics cannot go against the law of the country, law of the land. As you can see, if a law of a country prohibits a practice, a code of ethics cannot approve it. So code of ethics is in check with the law of the land. So you can see the example here. So this is more definitions of medical ethics. It's the subject concerned with moral principles for the members of the medical profession. So what is the scope? It deals with how these medical professionals should deal with each other, how they should deal with their patients, and how they should deal with the state. The main aim is to honor and maintain the noble traditions of the medical profession. And since this medical ethics, since these rules, since this code is done by the group of professionals from the profession itself, it's friendly, and it also helps the standards, the profession to be practiced in standards. So what does it mean to have, why do we need to have a medical ethics, code of medical ethics? So if someone has graduated and signed a declaration and has been willing to practice in that country, instantly that someone is assumed to be accepting the codes of medical ethics of that country. What does that again mean? In other words, if you have accepted a certain code of conduct and have willing to, you are willing to abide by those codes of conduct, it means you are also willing to accept the consequences in the unlikely event of disobedience or violation of such codes of conduct. That's what it means. So why do we need medical ethics? Beyond the legislatory actions of the state, it's another controlling influence, another controlling mechanism for medical practitioners. So pretty much you cannot put everything in the laws to govern the medical professional or to govern any profession. It's not, everything cannot be stated in the law of the land. So you need a code of ethics so that it could act as in additional influence on the medical practitioner. So what forms the medical ethics? Back in the days, it was believed that whatever the physician thinks is good to the patient, however the physician acts, it was assumed that he was right. Whatever the physician thinks was good to the patient had to abide. But currently, basis of medical ethics has evolved so that it places the patient at the center. So the doctor is now assumed to think that the patient is the reason for the patient's existence. If the patient is not treated well, the patient stops coming to the health center seeking for the doctor's help, then the doctor's existence becomes nullified. So you need the patient. The patient is the reason for your existence. So this is the current background for medical ethics. So this is the historical background. In 1970 in the US, this was the principles, the first well-formulated code of ethics in modern days. This was formed by Bishop and Childress. So these were the basic principles that they put So the first one is to do no harm. The second one is to do what's actually good to the patient. The third one is to respect for autonomy. That is to respect for human dignity, freedom, and free choice of the individual, and more importantly, to facilitate in every reasonable manner so that the patient makes a free choice. And the other one is natural and distributive justice in the distribution of healthcare, which means distribution of healthcare in equity, that is in proportion to their need, not inequality, but inequity. So these were the 4 principles recognized in the first well-formulated code of ethics. However, the first code of ethics historically was the Hippocratic Oath, as you might know. Hippocrates was a father of Western medicine. He lived in the island of Greece in the 5th century. So he had formulated a code of ethics that was up to recently the oath that medical practitioners took upon graduation. However, there is also the Declaration of Geneva that was first formulated in 1948. This declaration has been modified in repeated terms. And the last one is in 2006, the Declaration of Geneva of 2006 edition. So this is the one that most medical schools make their graduates swear upon graduation. This is the oath. The Declaration of Geneva of the 2006 edition is the one currently at work. So it's not necessarily this one in exact terms, but the main content streams from this basic concepts. So I'll leave this for you to read it, to go through it. But it's important that you know what the declaration you sign or the oath you take at the end of graduation, for you to see the contents, so that you would know what's right, what's wrong, what's allowed, what's unethical, what's unprofessional, and what's expected of you and what's not expected. So I suggest that you all go through this list, and so that you would be informed. So if there is a declaration that you take upon, if there's a declaration that you sign on, so a deviation or violation of those code of conduct would be regarded as unethical conduct. That's what it means. So who decides that an act has been ethical or unethical? Or who defines ethical medical acts and who defines unethical medical conducts? It's usually medical councils. In our country, there is a committee of medical legal matters. It's not actually a medical council, but there is a body, a party in the authority for food and drug, I don't know, DACA የሚባለው authority ውስጥ there is a subgroup so that it deals with medical legal matters. It's not actually a medical council. A medical council has a certain structures, but there are I don't know, initial steps in our country that are being taken so that hopefully in a while there would be a fully formulated medical council in recent years. So medical councils are globally the authorities that define medical ethics and also that arbiter claims of unethical conducts by medical professions. So functions of medical councils, why should you have medical councils? What's the benefit? So that these are the benefits of having a medical council in one country. They keep undergraduate and postgraduate medical education. So they would decide which ones fit for undergraduate medical schools, which one do not fit, what are the subjects, what are the curriculums to be included in undergraduate studies, what are the curriculums and disciplines to be included in a postgraduate medical education, when is a department said to be fit to give a postgraduate medical education, or even to be fit for as an academic institution or just a working department. So they regulate the quality and the standards for undergraduate and postgraduate medical educations. The other one is medical qualifications, who is fit, who is allowed to practice in the country. The third one is register of medical practitioners. We'd see this why it is essential to have register of medical practitioners on a level at a state's level. The fourth one, they advise Central Health Ministry whenever a physician or a medical practitioner has been sued for disciplinary actions. It also has the function of issuing of warning notices and disciplinary control. So in short, what it means is you would have a body concerned with this activities regarding the medical practice in the country, regarding the practitioner, regarding the practice, regarding the education. So, and the last one you could see that prescribing a code of medical ethics. So I'm sure for most of you who have been trying to get scholarships abroad and all, you have been demanded to get letters of good practice and good conduct, or recommendation letters and all. So if you have a medical council in your country, it would be easier. So you would know where to go to, whom to contact, which office is concerned, and then you'd have also your record there. So they would know if you have been a good practitioner, or if you had warning notices issued under your name. So it would be easier than going around into individual instructors for references and all. So it would make these things structured and easier to approach. The other one is CMEs, sponsoring and organizing CMEs. It's the one like we're doing now. So when you have medical councils, and if they are responsible for it, so the medical practitioner would know where to go to. We wouldn't be wandering to this post and that. If the medical council takes the responsibility for the continued medical education of the medical practitioner, so then you know where to go to for those continuous medical educations. So the other one is prescribing a code of medical ethics. So in our country, I haven't come across a code of medical ethics. I have come across two books. One is by Professor Amda Mariam, I think, who has been practicing in Black Line, and he has also been an affiliate for Gondar University. And the other one is by Dr. Melkamu Maaza. He has compiled a book. I think I've shared it, or Dr. Elias has shared it to you, the book. So those are the relatively compiled volumes that I have come across. I haven't seen a code of medical ethics for the Ethiopian medical practitioner from any legally authorized body otherwise. So why do you need a medical register? One of the functions of a medical council is to keep a medical register. So it would define who is a fit and registered medical practitioner. So no one can hold himself out to the public as being a registered medical practitioner unless he has fulfilled the criteria of graduating from a recognized medical college, and he has also gone through the process of registering his name on the registered medical practitioner. So if you suspect that a certain clinic or a certain physician or whatever is not fit or is not from a recognized medical college, you can just go and check with the National Medical Registry, so you could see it there. Or even better, if this medical registry is mandatory for any medical practitioner to be known as a registered medical practitioner and to become allowed to practice in the country, he's also supposed to post his registration medical number, his license and all. So this is the benefit of having, essence of having a medical register on a country level. So it has also the advantage for the medical practitioner to be registered on the medical register. So these are the following privileges that once a medical practitioner is registered in the national registry, he enjoys the following privileges. The first one is, if you're registered, you're set up and entitled to a medical practice, a clinic, or anywhere. You're also allowed to prescribe, legally allowed to prescribe medications. So you can hold official and semi-official appointments. You can sign, you're allowed to sign certificates. You can perform medical legal autopsies. You can be witnesses, expert witnesses at courts. You can be exempted from serving. This vary from country to country, the privileges a medical practitioner enjoys. So usually, since you are a registered medical practitioner, you can be exempted from military services and from serving on a jury. Most medical councils allow the exemption. Also, you can ask for your fees in a court of law in a situation, in an unlikely situation where the patient refuses to cover expenses. So why do you need prescription of code of ethics and disciplinary control? So medical councils hold subcommittees to define code of ethical behavior. And then that would mean if you have a prescribed code of ethics, then you can have a disciplinary control on the violation of that ethics. So disciplinary controls by medical councils could be warnings, notice of warning, and penal erasure of professional license, depending on the gravity of the unethical conduct. So penal erasure of professional license could be as well temporary or permanent. So it's that same medical council that can allow the temporarily erased medical professional to resume practice. If it's a temporary one, you also need a paper of reintroduction so that your penal erasure is no more effective. So if it's a permanent one, it's called professional death sentence or professional homicide. And it would mean the practitioner is deprived of all the privileges of a registered medical practitioner. That would result in a criminal negligence if a medical practitioner that had his privileges denied through a professional death sentence to be found practicing based on previous knowledge without having the license anymore. So when do medical councils entertain an act of medical misconduct, ethical misconduct committed by a registered medical practitioner? Only when the complaint has to be written, and it can come from the public, or it can come from the colleague, a coworker, or a hospital staff, or whatever. But it has to be in a written form, or when a medical practitioner is convicted by a court of law. So this is to show the usual steps. This is adopted from an Indian book, so that's why you would see the name India Medical Council of India and IPCs of India, PNDT Act, because but it since I thought it sums up the whole process, the usual steps adopted in a very better manner. I have copied the diagram as it is, so go through it and you'll see. And also decisions usually by the medical council can be appealed, and the final decision, most countries have state medical councils and medical councils for the whole country. So the final would be the final decision would be by the medical council of the country. So what are ethical and unethical conducts? What does medical ethics include. So as we have discussed before, it is duties of a physician towards the country or the state or the government, towards his patients and with his colleagues, and towards his profession. So currently, it's very difficult to find any medical activity or doings of a medical professional that the medical ethics would not have considerations about. So currently, the medical ethics have expanded to include a lot of concepts as informed consent with doctor-to-doctor relationships, medical confidentiality to research on human beings, from accidents to custodial tortures, tissue retentions to organ transplant acts, euthanasia, malingering, a lot of things. When a medical council considers unethical conduct, or when a medical council considers a sue from the public or whoever on a medical practitioner, the ones listed in the medical ethics are not exhaustive lists. The code of medical ethics is always improving, so there would be conditions that may not be listed in the code of ethics, but still the medical council has the power to entertain anything, even not listed in the code of medical ethics. So unethical conduct needs a definition. It means unethical conduct is also known as infamous conduct or professional misconduct. So it's a conduct on the part of the medical practitioner during the practice of his profession, where his colleagues, professional colleagues of good reputation and competence would regard as disgraceful or unreasonable or dishonorable. So it's a code of ethics, even infamous conduct or unethical conduct is defined by the professional colleagues of the same caliber. It's not a rule of dogmatic nature. It's what professional colleagues of good reputation and competence call disgraceful or dishonorable. It may not necessarily be what's wrong in the eyes of the law. It's just for the profession, the colleagues of good reputation and competence would think of that act as disgraceful or dishonorable. It's not necessarily a crime. It's not necessarily offense to the law. So this is what a professional misconduct and a professional error or negligence would look like when put in comparison. So for a professional negligence, negligence mainly deals with the doctor with patient. But professional misconduct or infamous conduct, it's whatever is in the code of ethics. It's about the duties of the doctor with the state, with other colleagues, with patients, and it includes a lot of things. But when you come to negligence, it's usually about the duties of the medical person towards patients. Professional negligence, you need the fulfillment of the 4Ds, maybe if you have attended the previous seminars. So there necessarily needs to be a proof of existence of duty, and that duty must be proven to have been derelicted or offended, and there should be a damage or harm on the patient. In the absence of a damage or harm on the patient, sue of professional negligence is not effective. But in case of professional misconduct or unethical conduct, there necessarily need not be a dereliction of duty and damage to the patient. So professional negligence is usually arbitrated at the court, but professional misconduct or unethical act is arbitrated before the medical council. So professional negligence can, as a result, can end up in the doctor being liable to pay compensation or be punishable, as in criminal cases, according to the penal code of the country. Again, you'll see the Indian penal code because this is copied from the Indian book. But when you come to professional misconduct, you don't really necessarily find errors before the law. So it's either warning or erasure from the medical registry, erasure of license. So if you want to appeal for a professional negligence, it has to go to the higher courts. But if you want to appeal for a professional misconduct, that would be for the state medical council. So those are the lists of unethical practices which constitute as what's termed as professional misconduct. So as I said earlier, this may not necessarily be offense in the eyes of the law, but they're still regarded as professional misconducts. So the first one is association with unqualified persons. So employment of unqualified or unregistered assistants. For example, to act as a nurse in your clinical practices, or to perform surgeries, or so. For example, if you employ a resident who has not yet fulfilled the criteria for graduation, or who has been dismissed from the academic stage, from the residency program, and he's still unqualified or unregistered, that is still unethical act. For it to be a negligence, there should occur a damage to the patient necessarily, so that it becomes a professional negligence or a crime. But it's still, even in the absence of the damage occurring to the patient, even though the procedure is made correctly, it's still unethical to employ a person who is unqualified or unregistered. The other one is assisting an unqualified person. Similarly, if you are the qualified one and the other one is unqualified, so it goes the other way. The first one is to employ an unqualified assistant. The second one is to assist an unqualified person. Also, having relationships with uncertified persons in enabling manner to practice beyond their scope. For example, if you refer patients to someone you know who has not undergone the proper trainings to do abortions, but you're still referring patients to him, you may not be doing the procedure exactly, but you're still having relations with uncertified, and you're acting in an enabling manner. So this would be still unethical act. The second one is advertising. So advertising is defined. What's the right way of advertising? What's the right number? Which media and all is defined differently in different medical councils. But however, the logic behind what makes advertising wrong for the medical practitioner is soliciting of a patient. This would mean inviting or gaining over a patient directly or indirectly by a group of physicians or by institutions. So you should just announce the scope of your practice. You should be registered and you should be a legal practitioner. Otherwise, you shouldn't try to gain patients in a advertising capacity. So that's wrong in the eyes of the medical ethics. The other one is you should not advertise in a way that makes your image grandeur in comparison or in contrast to your other colleagues. The other one is you should not also boast about the number of cases you have done, the number of patients you have cured, the number of operations you have performed successfully, and all. The other one is you should not acknowledge or advertise cures or remedies, and even permit the publications or report thereof through any mode. The other one is you should not advertise with the contract of compensations or otherwise with other favors promised to you. You should not also advertise anything, your practice or anything else, therapies, other appliances or whatever. So if a therapy is to be endorsed, if a research is to be done, they should come through the correct and ethical ways. You should not use your name and your fame to the public or your good name to the public to endorse those things. That is misleading and it's unethical. So direct advertising includes the following things. So all acts that are assumed to result in display of a physician in a grandeur manner are known as direct advertising, and they're all regarded as unethical acts. There are also other indirect advertising activities, so you would read this through. For example, direct advertising, unusually big nameplate, so that you could be your practice, the banner of your practice could be noticed from a very long distance. Inserting your name in a telephone directory in a special place or in bold types, or using mnemonics that are easy to remember so that the public would be deceived unknowingly to come to your practice. Third one is prescription paper rather than what is containing rather than what is legally allowed or expected of you. For example, prescription papers where your photos are printed in large, or where there is a logo of a medication that you advertise printed at the back of it, are known as direct advertising, and those are still unethical acts. So when can the medical practitioner advertise? So these are still to be defined according to the country. So, but these are in number 4 of direct advertising, you see what is medically acceptable advertising practices. So if you're starting practices all new, you can advertise, but this also needs to be defined with the number of advertisements that you can send, and it needs a definition with the type of media. How many times can you let a commercial run on a TV? How many times can you have it printed on a print media, on a magazine or something? So if you have changed your office, if you have resumed practice after you have been absent for a while, and changed the type of your practice. Indirect advertising includes the appearance on whatever is not listed in this, is also known as indirect advertising. So if you allow the use of your name on the price list of publicity materials, that's still an indirect advertising. You're not actually making the advertisement actively, but you're still having that impact. So appearances on broadcasting or televisions, which may have the effect of advertising. If you're there to give speeches on a public interest, that could be fine. Maybe it could also be your duty to do so. But if you do it in an advertising manner, for example, if you're on a TV to speak of COVID, and then you go on advertising that your clinic runs the test at a lower price than what's publicly available and all, that has an advertising effect, and so that's also unethical. So adultery, like I said, it may not be an offense in the eyes of the law, depending on the law of the country, but it's still unethical for a doctor to use his position to seduce a female patient into a sexual act, or a family, or even an attendant. So a doctor ethically should not involve with his female patient, or the female patient, otherwise with the female patient or with the family. So it's still unethical. And the other one is abortion. Abortion could be a professional negligence. It could also be unethical. So if you were there in a procuring or assisting or attempting manner of an illegal abortion, it's still unethical act. But if you have performed a criminal abortion, that's a professional negligence. So avoiding consultations also while it was needed and the patient could have benefited from it, it's also an ethical act. You might not have done any damage to the patient. The patient might have done it through his course well, but in the occasion where he could have benefited from a consultation, if you have been avoiding it, it's still an ethical act. Also, snatching away a patient who was under a care of another practitioner, whom you know your friend of the same profession has been taking charge. So if you snatch away that patient, if you coaxed, if you solicit it in any way, solicit the patient in any way, still it's a, or if you go behind your friend who's the attending physician and you extend what do you call consultations, if you extend consultations, if you extend advices, or if you work on so that the patient thinks that you're the better physician and not your friend, so it's still an unethical act. The other one is writing prescriptions in a secret formula where only the pharmacy you are sending it to can only understand. So prescriptions should be written in an illegible handwriting. They should contain medications that are known by the modern and scientific world, and no secret formulas should be included in your prescriptions. And here comes along with this comes along with using illegible handwritings, not actually signing your names, abbreviations, putting abbreviations so that you cannot be stressed back from the prescriptions you give out, are also unethical acts. So your name should be written in a very explicit manner, your qualifications and all, and your handwriting should be legible. Or if you're printing out prescriptions, that would be better. But still using non-standard abbreviations and secret formulas on prescriptions is still an ethical act. The other one is commercialization of a secret remedy. You're given a professional license so that in the assumption that you have fulfilled your course and the criteria to practice modern medicine or whatever licenses you have taken from the responsible council, you should stay in that code of conduct. Otherwise, secret remedies and solutions, whatever, are not, if you use them or even if you commercialize them or advertise them, or if you make patients use those things, or if you introduce those secret remedies in any way to the patient so that those remedies get better cells, it's still an ethical act. It could even be a professional negligence if the patient sustains harm due to a secret remedy not known by the scientific standards. The other one is improper association with drug manufacturing firms, pharmaceuticals, and allied health sector industry. This is a very burning topic and it's evolving. The code of ethics regarding this concept is ever evolving, but generally it would include gifts, receiving gifts, traveling facilities, hospitalities, accepting monetary grants or cash, research, professional autonomies, affiliations, and endorsements. So I would recommend you all to read articles on this because evolving concepts ስለሆኑ settled የሆኑ ነገሮች ብዙም code of ethics ላይ አታገኙም. So it's a ongoing concept. So I would recommend articles for you to read. The other one is receiving or giving commission or other benefits from or to a professional colleague, a manufacturer, or a trader. This is still an ethical act. It may be very difficult to prove, but it's still, if you have if you have been sued for such act, it would destroy all your reputation. So it would take a lot of, I would recommend a lot of care and precaution before you involve in acts of receiving or giving out commission. I would generally not recommend it. It's not ethical. It would also destroy your whole reputation. So dichotomy or fee sharing or fee splitting. So what this means is, let's say you're an internist practicing in a certain hospital. You have your clinic, you're practicing in a hospital. So let's say there is a surgeon in your hospital practicing in the same hospital as you. So, but if you have a surgeon who is practicing outside of the hospital, it would mean whenever you encounter a patient with a surgical condition, rather than sending the patient to the concerned department in your hospital of current practice, you send out the patient. You convince the patient and you send out the patient to your surgeon friend practicing elsewhere. For that, you get a commission from your friend. So it would work otherwise too. You're receiving commission or paying commission. It could also mean that you ask your friend to send patients for you, and you'd offer commissions on that. So dichotomy or fee sharing or fee splitting is the proper term for it. Also, issuing false certificates in respect of birth, cause of death, illness, injury, and vaccination. Talking disparagingly, untoward comments about your other colleagues, even in the occasion where you have seen and not so good recommendable acts or managements. You're not supposed to, if you want to, you can expose the act. If you think it's a very unethical and the patients are not actually benefiting from his acts, you can report it. But it's not nice, it's not ethical to go out and talk disparagingly about your colleagues. Conviction by a court of law is also not unethical. It's still professional wrong and as well unethical act. So those are examples of unethical acts. If you define unethical acts, you also need to define ethical conducts. What is the benefit? If you know what's unethical, you're practically defending yourself. If you know the list, if you know what's not recommended, if you know what's most likely to get you sued, you would protect yourself. You're unlikely to engage in such activities, and so that you'd stay safe. But definition of ethical conducts would further benefit the patient. Unethical conducts would spare the physician. Ethical conducts, definition of ethical conducts would, beyond sparing the physician, would benefit patients. So since the basis of medical ethics or ethics of any profession is to put the client at the center currently, it's very essential that ethical conducts become defined. So the first one is declarations and the second one is duties. So it's ethical for a medical practitioner to sign declarations, to know the contents, to be aware of what you're supposed to do and not supposed to do. So declarations are the first one, and the second one is to be aware of your duties, what's expected of you, what would benefit the patient more in your practice. So these are the parts of the ethical conducts. So declarations, this is ideally what every medical practitioner should do upon fulfillment of medical education and having the license. A legitimate practitioner in a country should be provided a copy of the declaration. You should read it, and then you should submit a duly signed declaration. So regarding duties, this is going to be a very vast topic, but we would divide duties into general duties and voluntary duties, compulsory duties, duties to the patient, duties to the other professional, and all. So in general, the physician, from the general duties, the physician should uphold the dignity and honor his profession. And the prime objects of the medical profession you should be aware is to render service to humanity. So gaining financial gains is a secondary consideration, but you should know that why you're there as a medical professional is to render service to humanity. So a physician should have a reputable character. You should be an upright man, instructed in the art of feelings. His character should be pure, and he should be diligent in caring for the sick. He should be modest, sober, patient, and all the good characters from a professional. And he should honor his profession in all the actions of his life. So this would mean you're supposed to keep the your activities, your actions in line from in and out of your medical practices. So you should also be an upright person in your domestic existence, in your existence in the public, in your existence as a citizen. So upright personality is expected everywhere, not just at the medical practice only. So this is no person other than a doctor having qualification recognized and registered by a medical council should be allowed to practice modern system of medicine or surgery. So on the general duties, apart from the characters, the physician is also expected to maintain good medical practice. This should mean to continuously improve medical knowledge and skills. You owe this to your patients. You need to treat your patients with updated knowledge. And they should also benefit from the improved medical knowledge and skills. The other one is the physician should practice methods of healing based on scientific basis. And he should not associate professionally with anyone who violates this principle. So as a physician, you're not expected to, associate with people and refer patients to traditional healers, for example, or to some religious activities that you don't have a scientific basis for, or that are actually harmful. So you cannot just, the patient may have the right to do that, but it's not right to advocate such practices. The other one is you're supposed to be a member in medical societies. This would keep you abreast to improved medical knowledge and skills. And it's also in a membership in medical societies should also offer you indemnity insurance. So whenever you are sued by a medical council or by a court of law, you can transfer the condition to your medical society so that they would run the case in your place. So membership in medical societies, beyond the advantage of helping you keep a good medical practice, that would also give you an indemnity insurance. The other one is to participate in CMEs. Some countries, I think it's also started in our country currently, you need to fulfill a certain number of CPD points, CU points, so that you would have your licenses renewed. So some countries mandate that, some countries don't. However, you need to keep updates with your medical knowledge and skills. So CMEs are one good way. So it's ethical. It's a good practice to participate in continuous medical educations. It's part of your duty. Maintenance of medical records. This I cannot stress enough. It's also a legal duty, but it's also an ethical duty. So every physician shall maintain the medical records pertaining to his patients, and records should be clean. They should not give out suspicion of forgery. They should not be tearing out of pages or inserting of new records in old documents and all. And the period of time you're supposed to keep your charts for your outpatient records or for your inpatient records, for laboratory reports, for if you're doing with microscopes for keeping microscope slides, your institute should have a defined period of time as to when, as to how long you're supposed to keep medical records. That said, you're also supposed to record everything in a illegible handwriting. If you're typing, you should also type something sensible information. You should avoid omitting according to your convenience. And also keeping a medical record is one of the general duties. The other one with medical records, it should be available to a legally authorized body requesting, or even to the patient. This is also to be defined. The time by which, the duration of time by which a physician is supposed to make a medical record available is also supposed to be defined. It's usually in hours, because if you give days or weeks, it's assumed that the physician or whoever is in charge could use that period of time to alter records. So at request by the patient or any authorized attendant or legal authority, there should be a defined period of time by which the medical practitioner should make the medical record available. Medical certificates also require their own registers, and copies should always be maintained. So display of registration number, this is the other duty. So some countries request that medical practitioner wear chest badges with their photos, with the authority, with the authorizing medical council, and with their suffixes. If they are authorized as consultants, if they're authorized as subspecialists, or whatever. Some only require that they post it on the wall in their consultancy rooms. Some others require that it appears on the prescription papers, on the certificates, or whatever is given out from that hospital, from that practice, should contain the registration details. So however, display of registration should be displayed somewhere. It's a duty. The patient whoever comes to your practice and shouldn't wonder if you're a registered practitioner or not. You should have it displayed somewhere. The other one is use of generic names. This would go back to the use of secret remedies, and also to endorsements and advertisements of certain brands. So as much as possible, a physician is supposed to use generic names for drugs. The other one is whenever you witness unethical conduct, you're expected to expose. It could be your colleague, it could be your relative, it could be your friend. But since Code of Medical Ethics, you have signed the declaration, and since the ethics puts the patient at the center, the interest of your colleagues doing unethical acts must be placed secondarily. So if you see unethical conduct, you should expose it. So payment of professional services. The physician engaged in the practice of medicine is always supposed to give priority to interest of patients. The service you give should not be limited by the financial capacity of the patient. But what you could do is, or what you should do is announce your fees, the amount you're going to request from the certain, if it's just consultation, if you're going to do laboratory examinations or whatever, if you're going to do operations and all. And that amount you have announced it at the beginning of the service is the one going to last through the entire course. You cannot modify payments after the patient has rendered service already, after you have rendered service to the patient. So it's unethical. First of all, you should not grant cure in your practices. The whole point of medical profession is not to cure the patient. Curing the patient comes as a method of alleviating the pain of that patient. Cure definitely will alleviate pain. So otherwise, your duty as a medical practitioner is to give the patient painless days. Quality of life improve ለማድረግና to charge him a day free of pain. So do not grant cure and do not base your payment of service based on the cure you give. So no cure, no payment is a very unethical base of contract. So if your service is, if you're going to be paid by the state or the government, or if you're already being paid of your salary by the hospital or anything, you should not solicit the patient into giving you extra rewards or extra monetary grants. If you're serving for free, or if you're already getting your salary from a different body, the patient should not be coaxed into paying you more. So those are the general duties. The next one is compulsory duties of a medical practitioner. These ones are the mandatory duties. So the first one is compulsory notification, and the second one is responsibilities to the state or to the government. So what are the compulsory notifications? Those are notifications of births, it's events, notifications of events that you should necessarily do. So this is also to be defined. The duration of time you have before announcing such events is to be defined by the medical council and also in the laws of the state. So most medical councils, most countries say births should be notified in 72 hours. Deaths should be notified in 24 hours. The other one is infectious diseases and food poisoning from a restaurant. Some countries, they also mandate reporting or notification of industrial disease. So these are your compulsory duties. If you have, it's your duty to fill birth certificates, to send notices to the proper authority regarding births, deaths, infectious diseases, and food poisoning from a restaurant, from a point source. The other one is responsibility to the state. So responding to emergency military service, reporting case of homicidal poisoning or suspected homicidal injuries. If you find a patient, if you're examining a patient and you think he has been stabbed or shot by a certain someone, and if you think it's of a homicidal nature, you're supposed to report it to the police or to the right concerned authorities. We'll see how to do it later. So other matters of crime, like rapes or criminal abortion, you're supposed to report it. These also include child abuse, domestic abuse of the elderly, or domestic gender-based domestic abuse. Also reporting unnatural deaths, it varies from countries to countries. Some countries request the physician to report all cases of accident, all cases of homicide, and all cases of suicide. But some countries only require the physician to report cases of homicide. So those are the compulsory duties. What are the voluntary duties? What does it mean by voluntary duties? The duties that you overtake voluntarily because you want to, because you enter into a contract and then these duties follow. But you also have the opportunity, the chance not to enter the contract. So these duties are not supposed to, are not expected of you. But once you have entered into the contract, these duties are expected of you. They are called voluntary because you have the option of not engaging into this contract. So these are the voluntary duties of a medical practitioner. This is not an exhaustive list. However, these are agreed upon by most medical councils globally. So responsibility to patients, medical examinations, these have their further details. We'll see some of them and we'll discuss some important concepts. So responsibility to patients, medical examinations, operations, issuing of, so the voluntary duties in when examining patients, when doing operations, when issuing certificates, regarding prisons and reformatories, regarding post-mortem examinations and all. We'll see a few of them in brief details. So responsibility to patients, a physician or a medical practitioner of any sort is supposed to have the responsibility to patients whenever he has entered the unimplied contract. Once the implied contract is formed, the physician has the following responsibilities to his patients. The first one is to continue to treat. This is a doctrine by itself, and it has its exceptions and its conditions. We'll see it later. The other one is to impose a reasonable care and skill with keeping abreast of recent advances. This is also a responsibility. Professional secrets, they form part of the implied contract. Hence, breaching of professional secrets, breaching of professional secrecy is assumed to be breach of the contract. Also, not undertaking procedures beyond skill. Special precautions to be taken in case of children, incapable adults, and elderlies. Special precautions in dangerous drugs and poisons. Consultation is also your responsibility once you have entered the implied contract. Withdrawal and replacement from care of that patient. Generally, the consensus currently is do not withdraw from the case without informing and arranging potentially a replacement. So regarding the medical examinations and operations, the physician has a duty, ethical, moral, and legal duty to take consent. And consent is said to be valid. We'll see it later. Consent is to be taken after the nature, extent, risks, and alternatives and prognosis is explained well. Secrecy is to be maintained. Laboratory aids and x-rays, they are to be taken. This is easier said than done. It's very difficult to decide unnecessary and necessary laboratory aids and moments to take x-rays or not. But however, it's listed. And identification of patients. This is very mandatory, and it's your duty to duly identify whoever you're treating. This is very important. You cannot blame it on anyone else. You have to make efforts to know and make sure that you're treating the right person. So this is the condition you see with operating on wrong patients, operating on the wrong organ and all. So it's your duty. You have to identify. And there are ways to identify patients. The first one is if they are capable to make them spell their name, call their name and their condition until with their names, middle names and last names. And if possible, to make them spell whatever conditions they are presenting to, so that you would know which patient is which. The other one is to use wrist badges to attach photographs on the charts and all. So by any means necessary, you have to identify and make sure that you're treating the right patient for the right condition. And the other one is keeping safety, precautions of safety. And the other one is no experimentation. Whatever is not scientifically ascertained, whatever is not on the textbooks, whatever is not legally allowed, you're not supposed to experiment on the patient. During medical examination and certificates, medical legal examination, proper authorization. If you're going to do examinations for legal purposes, if you're a forensic physician, for example, you have to make sure that the requesting authority is the right one. For example, it would be listed, it would be announced in the medical council or in that discipline. So you have to know that the proper authority, it's the proper authority. The request is from the proper authority. you have to make sure, you have to see, you have to go through the entire request. And you have to know that it bears the name of the facility, the authority, the seal that is signed, and whatever is requested is within the mandate of that authority. The second one is identification. We have said that, and here you're supposed to use photos and use identification marks. This is mandatory in medical legal examinations. Identification marks could be natural or acquired marks on the client to be examined that you think the combination of which is unlikely to be found in that same combination in somebody else. Then verification of facts. You need to preserve materials when requested. This is also your duty. In case, if you have the laboratory and you had to examine a case of poisoning, you have to preserve whatever to be sent to the laboratory. You cannot omit preservation of material while you had the chance. This is your duty. So, copy of medical legal examinations and certificates should be preserved. This is very essential. You have to have a registry, you have to have the original copy, and you have to have a copy of an original copy. So the same as the one you give to the authority, to the requesting authority. The report, the certificate, you should also keep an original one in your whatever archives. So certificates, what's the requirement? The data you put in the certificates must be true to the best of the doctor's knowledge and belief. It is important that it's to the best of your knowledge. You're not supposed to know the minor details or the minor manipulations the patients or the clients do, but you have to make sure whatever you're writing is unbiased and it should be a bona fide statement. It must be to the best of your doctors, to the best of your knowledge and belief. So regarding prisons and reformatories, the doctor has the duty to check on facts regarding pregnancy, to check diets, inspections of toilets and lavatories, checking safeties and hygiene. So postmortem examination. So if just because you have the dead body and because it's dead, it doesn't mean you're free to do anything with it. So if you're doing for laboratory and research purposes, you have to have a scientific background, and also you need to obtain consent. If you're obtaining the body or the sample for a medical legal purpose, if there is a medical legal request attached to it, then you cannot experiment or preserve for research and other purposes. So points of further discussions, these are in the voluntary duties of a medical practitioner. These are the things that would need a little briefing, as these are very important. These are the conditions that you find and get challenged with in your day-to-day practices. So this implied contract, continue to treat, professional secrecy and privileged communication, consent, consultation, and duties of a patient are the concepts that we would see in brief in the following slides. So what does it mean when we say a doctor enters into an implied contract with a patient? An implied contract is a contract that is not written. It's assumed that the patient understands, the patient is willing, and the doctor understands the condition by which the patient is there for. So it's not written, but it's still legally effective. So it's not always possible to enter into a written contract all the time. It could be in an emergency, and there's also doctrine of common knowledge, or if a patient walks into a hospital, if he's mentally accurate, you assume that the patient is there, it's a hospital, he knows. So you assume that he's there to get interviews to give history and to be examined and to be treated. But they're still, it's still legally effective, and a violation, since it's a contract, violation from either sides still makes the defaulting party liable for damage. It's similarly legally effective. Just because it's implied and it's not written, it does not make any of the parties free. The patient is not free to claim anything, and the doctor is not free to do anything. It still has its boundaries. The doctor has the right to choose. That's why it's called, until this implied contract, doctor to patient contract, is established, the doctor is free, is not bound to any damages, to pay, liable for any damages. So the doctor has the right to choose whom to treat. But once the doctor has chosen whom he treats, whom to go into this contract into, the responsibilities would follow. So in an implied contract, this is what's assumed. Once the doctor has entered an implied contract with the patient, he must continue to treat the patient whom he has accepted with reasonable care and reasonable skill, and to keep inviolate of his secrets. He should not undertake any procedure beyond his skill. Just because you did not have a signed contract with the patient, it doesn't mean you're free to apply any uncertified or unscientific method of treatment. No, you're supposed to apply a scientific principle with reasonable care and reasonable skill. And just because you have not, the patient has not signed a contract with you, it doesn't mean you're free to go out and spill the secrets he confided into you. You're still legally bound to keep secrets which you knew by your professional capacity, even though it's an implied contract. So what are the exceptions? While still there is a doctor and a patient, or a doctor and a client, where this implied contract is not established. If it's a first aid in an emergency, the doctor does not have this implied agreement. You just do what's a life-saving measure, and then you send it to the attending physician. You send the patient to an attending physician. If you have a pre-employment medical examination, it's assumed that you're not there in your treating capacity. So there is no doctor-patient relationship. You're just there to examine. So you're not, as long as you're not there in your treating capacity, you're not supposed, reasonable skill, reasonable knowledge and all is not as such expected of you. When you perform examination for life insurance, most of all in these conditions, you're not supposed to keep the secrets. It's assumed that the client is there to be examined, so that knowing that his results would be communicated with the insurance company or whatever, the employer. When you're examining by the trial court, when you're requested to examine the patient or the client by a court, there's no doctor-patient relationship. Also, for lawsuit purposes, when you're examining for lawsuit purposes, there is no implied contract. For most of them, most of these categories are put here so that the doctor is not accused of breaching professional secrecy. These are conditions where it's known, it's understood that the information, the secrets that the client or the patient tells the doctor are going to be relayed to whoever is requesting the examination. So what does it mean to continue to treat? The doctor, once into having entered this implied contract, he has to continue to treat the patient in all conditions, except if you think the patient is well and has recovered, you can discontinue the treatment. If the patient is under some other responsible caregiver, you can also discontinue to treat. If you have given due notice that would be unavailable, so that the patient would look for other caregivers or substitutes. You're not supposed to find a substitute as a caregiver, but you are supposed to give due notice, enough time, so that you could relay the patient to another caregiver in a responsible manner. So the patient has signified his intention of changing the doctor. So if he tells you that he's already consulting someone else, or if he wants to enroll into another doctor's care, then you have the right to discontinue to treat. If the patient is not fulfilling his duties, if he's not cooperating, if he's not following your orders, and if he's not communicating well, his reasons of not executing his duty, then you can discontinue to treat. The other one is if the patient does not pay, also you're allowed to discontinue to treat. So if you also think it's a malingering patient, there is no concerning and genuine illness, you can also discontinue to treat. So these are the conditions where you can discontinue to treat. Otherwise, once you have entered the implied contract with the patient, you're supposed to continue treatment. So what is a professional secrecy? This is a very important point. What's a professional secret? It's a secret which the doctor comes to know in his professional capacity. It's a secret that you get to know because you're there as a doctor. It's a secret that the patient tells you in the belief that telling those secrets are the only ways that you'd get treatment. So those are the secrets learned by the doctor in his professional capacity. So those secrets necessarily need not be confided by the patient. They could be told by the patient. Those are also the ones could be noticed during examination by the doctor. They could be observed in a domestic life, in the course of domestic life. So it doesn't matter how the doctor learns those secrets, but since those are the secrets that he knew because the person was brought to him as a patient, then he's supposed to keep them as a secret. So professional secrecy is part of the implied contract. So if you have a contract, it means when you deviate or violate that contract, there are consequences. It would amount to breach of contract. So there are the concepts of privacy and confidentiality. Privacy is a bit narrower. Confidentiality is a bit vaster. So I would recommend you to go through these terms on your own. So however, the patient needs also to consider modern day medicine. It's a multidisciplinary approach. So beyond the attending physician, there would be a lot of people in treating capacity that would be informed about the patient. So the patient needs to consider that it cannot be just a single doctor and a single nurse. There are other multiple paramedicals, even from the medicals, there could be consultants, there could be specialists, subspecialists. Also, by the virtue of the medical school training, there are medical students, interns, and residents. So these people would need to know all the information about the patient. So the patient needs to consider these facts, the virtue of medical schools, and that currently the modern approach is a multidisciplinary approach. So before you confide a secret, professional secret, the one you learned because of your professional capacity, there should be a consent. So there is a concept of consent to disclose. So these are the conditions that you're supposed to take valid consent before disclosing. Ideally, you shouldn't disclose. Whatever you know about your patient is supposed to stay with you, ideally. But there could be conditions where you need to disclose. So make sure that you have the consent to disclose. So just because patient has an attendant, patient is conscious, patient can consent for himself, and patient can decide for himself, then it's not implied that you have the mandate to inform whoever is attending, even if it's a family, if for the adult patient, even if it's a family or a spouse or anything. So be conscious before you disclose anything about your patient. When you reply to queries of relatives based on questions about prognosis, for example. So if the patient does not consent, just because the relatives are paying for the patient's medical bills or whatever, they don't have the mandate to know, and you don't have the mandate to disclose. The patient has to particularly give consent to disclose. Even when you are disclosing to public or statutory bodies, you still have to ask for the consent of the patient. Even to husband, wives, and spouse, while in a marriage or even after a divorce or nullity of marriage. Of course, there are exceptions where you're supposed to disclose nature of illness, but still, just because someone is a husband or a wife or a spouse, it's not a pass to know about that patient. So government requires examination of a government servant. Still, this is still a confidential condition. The patient has to confide. Yeah, we'll see the exceptions. So even if an employer or a master running a factory or whatever, so his servants, his employees run, let's say, an annual medical checkup, and then unless it concerns to the fitness on their work, or it enables them to gain sick leaves or whatever, except in those conditions, you still don't need to tell the conditions of the employees to the master, even if the payment is covered by the master. So insurance companies, it's assumed that the patient or the client has agreed for the information to be relayed to the insurance company. But however, it's only related to the one of current interest. And if you're asked on the condition of the client, where he was treated before at your center, you're not supposed to disclose. I mean, if the patient wants you to, you could, but you're only supposed to disclose conditions that are of interest to the company currently. Let's say a patient is hypertensive and he has visited your clinic like a year ago. He's on medication and you know that he's following at your clinic, and right now he is normotensive. So whenever the insurance company asks you of current condition, you just report that you have normal blood pressure records. That's it. If the insurance company asks for previous conditions, the client has to consent. He has to give consent to disclose. So the other one is pre-employment examination. This is also the same. It's assumed that the patient, the employee, is aware that his condition would be relayed to the employing company. But however, those are still going to be the conditions related to the fitness for the work or the leave. So prisoner under trial, some countries give different conditions for prisoner under trial and prisoner convicted. So a convicted prisoner is not supposed to consent when examined for medical legal conditions. But those under a trial where the conviction is not set yet, they have still to consent. They have the right to consent. So the same as condition on the death of a deceased person, you have to have consent from next of kin. So this is an example where a woman was examined by a doctor, and the doctor knows the family, and she was her husband was working abroad and living abroad, and she was receiving payments allowance from her husband's brother. So the doctor found out that the woman was pregnant, and since her husband is away, he has assumed that she was pregnant from somebody else, from an extramarital affair. So the doctor went on to disclose the condition to the brother of the husband who was giving her her allowances. So the patient here has sued the doctor, and she has been awarded money as damages. So there is no impending danger here. Nobody's nobody's to be hurt, at least in terms of health and other conditions where the doctor is concerned about. So he came to know this knowledge because he was a treating gynecologist. He knew this is a professional secret. So he was supposed to keep the secret to himself. But he rather went forward and told whoever was paying the allowance to the woman of her pregnancy. So the woman has sued and she has been awarded. So what's a privileged communication? This is the communication by the doctor to the proper authority. These are the conditions where the doctor is justified to disclose information about his patient as his moral or social duty, or what is expected of him, or in favor of the patient or in favor of the others around the patient. So privileged communication is to be done in a written manner. It's supposed to be given in an envelope. It's supposed to be sealed and marked as privileged communication, and it's supposed to be done to the proper authority. So these are the exceptions where the doctor is justified to disclose professional secret to the proper authority. So circumstances for privileged communication, these are just examples. It's not an exhaustive list. So regarding employers and employees, if health status of an employee causes an inherent danger to himself and others, a doctor should inform the employer. Of course, initially, the employee is supposed to be informed, and if he withdraws or if he opts for treatment on his own, then the communication is not necessary, except in few cases. But if the employee refuses treatment or abstinence, the doctor should go forward and inform the employer. So these are the conditions. Let's say a bus driver or a captain for a ship or an airplane is known to have an epilepsy or high blood pressure, a drug addiction or alcoholism, or has color blindness, then you shouldn't sign the certificate of fitness, and you should as well inform the employee to abstain from taking the job. But if he refuses and your advice and goes on to take the position at work, then you send a privileged communication to the employer. The other one is if the servants of a hostel suffer from any communicable disease, such as open case of tuberculosis, syphilitic ulcers, and gonorrhea. The second one is where a privileged communication is allowed is in the patient's interest. At times, the information of the patient's condition to his family could help for the patient to get proper treatment. But also, if a patient has a dangerous tendency of homicide and danger to others surrounding him, or if he also has a tendency to commit suicide, the doctor is supposed to tell those surrounding the patient. From suffering, when you find a patient is found to be suffering from venereal diseases, STDs, you inform the patient to abstain from sexual intercourse, or if he's getting married, you advise him not to get married until he is cured. But if he refuses, you're supposed to inform his spouse. Usually there are centers to do this privileged communications in the hospitals. But however, if there are no centers in the hospital you practice in, you can contact the patient directly, the spouse or the wife or whatever. So when suffering from infectious diseases, this is not only an ethical act, this is not only a privileged communication, this is a duty. You have to do this. So when you find an infectious disease emanating from a point source that could potentially cause epidemics or whatever, you're supposed to inform the proper authorities. So disclosure in the doctor's self-interest. Let's say a patient sues you in a court of law or sues an act of misconduct to your medical counsel. Then if you think disclosing the patient's condition, let's say, for example, if he's not mentally accurate, and if you think whatever he considers as unethical conduct is because of his failure to judgment what's ethical and unethical, you can go ahead and disclose that the patient is suffering from some mental illness that potentially has affected his judgment in suing you for unethical conduct. So in a court of law also, when you're supposed to show up as a witness, you're not supposed to offer a secret to the court, to offer to unveil a secret to the court, but if the court insists, then you have to give out. But this should as well be done in a written manner, and it should be sealed and offered as privileged communication. The other one is in criminal matters like child abuse, like rape or whatever. You're supposed to privileged communication covers you here. It's also your duty. So if you hide such evidence, it could even amount to negligence, not just unethical act, but negligence. In criminal matters, it's important. So let's say you examine someone who is accused of murder, you're supposed to report. Or if you see someone has been stabbed, and if you think it's of a homicidal intention, then you're supposed to report. So these are the things that we have discussed when a master sends a servant and when you're requested to give insurance reports. So the other concepts that needs brief discussion is consent. Consent by itself is a seminar of multiple sessions, but since it's very important and since it's something that you get in your day-to-day practices, I would try to discuss it in brief. So consent is could be defined as concurrence of wills. Wills again needs redefinition. So chief component of consent is whoever is consenting has been conscious and he has the knowledge of whatever he is consenting to. So if you have been willing, you cannot complain later. This is the background maxim for consents in medical. So if you are informed, if you know that a certain sport would cause you certain injuries, you cannot go back and complain that you sustained the injury. You knew, you are already informed. So what's a will? Since we defined consent as concurrence of wills, we need to define will again. Will is choice by a rational and sound mind dedicated to the effectiveness of the choice and the consequences. So when you're willing, it's not only when you're consenting through a will, you're not only consenting to the action, you're also ready and willing to accept the consequences of your action, your choice. So a consent in a medical practice has to be an informed one, valid, and from a sound mind. So what defines an informed and valid consent? It would be one not obtained by coercion, undue influence, fraud, misrepresentation, or misconception of fact. So if a person, for example, if you make a woman consent for abortion by threatening her to inform her husband of the condition, or threatening her that you would inform her husband that you'd tell on her extramarital affair, this is not a valid consent. If you're also telling that, if you're also making someone consent, informing him, let's say, some surgery would make the patient lose a liter of blood. So if you tell and obtain a consent that informing the patient that the amount of blood loss is negligible, then it's still misrepresentation of or misconception of facts. Yeah, so if you also make a woman consent for a sexual intercourse, if anyone makes a woman consent for a sexual intercourse by deceiving her under the influence of alcohol or any other hypnotic drug, that's still not a valid consent. So a valid and informed consent is one that's not obtained by coercion, undue influence, by fraud, misrepresentation, or misconception of facts. It's also one where it's not obtained from a person of unsoundness of mind, where a person is suffering from mental inaccuracy, intoxication, or immaturity of age. Age to consent has to be defined by the law of the state. So and age to consent for medical therapy has also need to be clearly defined. Age to consent for marriage, age to consent for medical treatment, age to consent for operations and all. And where minors are allowed to consent for such treatments, or where, even if it's a minor, where consents are not required, medical conditions where consents are not required, need also to be defined. So it would be very vast to cover all those things. I suggest that you go through those indications yourselves. So this is informed and valid consent, where it's not obtained by wrong methods and it's not obtained from the wrong person. So what are the types of consents? Those are implied and expressed consent. Implied consent, like implied contract, it's not written, but it's still legally effective. This is the most common type in hospital and medical practice. This is the one you encounter mostly in hospital practices. So there's also an assumption. So as a patient walks into the hospital and the doctor's station, it's implied that he's willing to be interviewed and examined. But the issue with implied consent, it should not exceed to few steps. So it would mean implied consent, not to procedures more complex than inspection, palpation, and auscultation. This is what you cover from an implied consent. So some medical procedures in which implied consent is readily apparent, if it's an emergency, and if the person is conscious and walks into the hospital with an emergency condition, you assume that he has given an implied consent, or you're not supposed to prove that the patient had consented because he has showed up at the emergency already and his condition was an emergency one. You're more bound to save the life of that patient to treat the emergency condition than to go through the process of obtaining written consent, expressed consent. So a comatose patient requiring immediate treatment. In this case also, some life-saving measures could be done, but it's advised for the physician not to engage into larger procedures, complex procedures like amputations and all. There could be conditions where amputation of a limb could be the only life-saving condition, or doing a craniotomy, opening the brain, opening the head, the cranial cavity could be the first life-saving procedure. So there is a way to do that. You can call for other physicians, you can call for the owners of the hospital and all, so that you could validate your action of engaging into a more complex situation through an implied consent. Mentally incompetent patient, when a legal guardian is unavailable, also this goes for in case of emergency. There is also an unwilling admissions could be done in case of mentally incompetent patients for mental institutions. So these are the scopes this implied consent covers: intoxicated patient, lacking capacity to reasoning, and any patient allowing treatment to proceed without objection. For example, if you ask a patient to take his blood pressure and he extends his arm, then even though he doesn't agree to the condition, what do you say, in an expressed manner, since he has not objected and since there is no harm, it's also considered as an implied consent. It's also the same for taking venipunctures, for taking blood samples. If he doesn't resist, if he doesn't express his refusal assertively, then you're free to assume that consent has been implied. So the other one is expressed consent. This is where the patient states in distinct and explicit language his agreement. Again, expressed consent could be oral or written. Because it's expressed doesn't mean it's always written. Expressed consent could be oral or written. It could still be verbal. So oral expression, it could explain, it could include verbal statements. It could just be nod of agreement, or again, absence of expressed refusal. So these are done for relatively minor examinations or therapeutic procedures. But if you're going to engage into more complex situations, it's always advised that you have a written expressed consent. In oral expressed consents, disinterested witnesses, where testimony of whom would not change later. If you have, lemsali, as a witness, a friend of the patient, when they later on get advised that they could get benefits if they sue the physician or the hospital for not obtaining their consent, a friend may not be a good witness. He could change his word. The testimony may not be reliable. So it's good to have a disinterested witness in case of oral or verbal expressed consents. So in consents, there is some room for extension, but this should be done in proportionality. Doctrine of extension is only appropriate in circumstances where the extension of the scope of the consent would save the life of the patient. So otherwise, consents should stay for the conditions they are given to. For example, you cannot extend consent for a diagnostic procedure to a therapeutic treatment. Let's say you obtained a consent from a patient for a diagnostic laparotomy. And then when you open the abdomen or the pelvis, you find out that the patient could also benefit from a treatment and surgical treatment. And then you extend the consent to therapeutic consent, then the patient could sue you. Even though you have benefited the patient, it's still mandatory that the patient gives his or her consent for both the diagnosis and the therapy. So the only exception for extending without proportion is where it's necessary to, where the procedure is necessary to save the life or preserve the health of the patient. Let's say you said you found what do you call, like postpartum hemorrhage, and you said it was only for exploratory condition, and then you found a bleeding uterine artery, and then you would be sued. It's not right to leave the uterine artery unligated just because the patient consented for diagnostic procedure. In that case, you should extend. Doctrine of extension is fully applicable. And then unreasonable, when it's unreasonable to delay a procedure until valid consent is regained. Let's say a patient has been anesthetized and you found a life-threatening condition. So you cannot wait for the patient to gain consciousness and to give you a valid consent. When the life of the patient is in question, you cannot do that. So you're supposed to apply doctrine of extension in this situations. Doctrine of informed consent, it's very important that a consent is an informed one. It's not only consent, it's also refusal, but it should be informed one. So what are the criteria for informed consent? It's an informed consent is fulfilled after the nature, purpose, and procedure of treatment with its benefits and effects. Alternatives should be explained if there are alternatives. Risks. So in telling the risks, it's only those that have substantial potential of appearing. You're not supposed to cover all potential risks, rare and theoretical risks. Also, adverse consequences and prognosis should be informed without exaggeration. This is some quote. A physician violates his duty to the patient and subjects himself to liability if he withholds any fact that's necessary to form the basis of an intelligent consent. So if in fear of just the patient would refuse to undergo the procedure, you should not withhold an information. Let's say you're going to do a myelogram and there is a substantial risk of the patient sustaining quadriparesis or paraparesis. You should still inform. You cannot withhold the risk of quadriparesis if it has a substantial chance of occurring, if it's a substantial risk associated with that procedure. So just because you're afraid that the patient would abstain from under the procedure, you should not withhold any information. So this is to say, there is no need to explain far remote or theoretical risks. You're not ethically bound to explain all the far and remote risks. What you should understand is uninformed consent is not something you do at a point in time. It's an ongoing process. And you would always benefit if you show the patient that there is always a room for discussion, that you're always there to answer his questions, to listen and to answer his questions, to address his concerns. So there's also a room for you to modify the consent you initially gained. So understand that informed consent is not something you once obtain, but it's always an ongoing process, a two-sided conversation extending over time. So who is responsible for obtaining the patient's informed consent? This is also a point very important for you to consider because it's always the attending doctor at the time in question who has the ethical duty, because that person, the attending doctor, is the best person to decide what information to tell, the mental capacity of the patient, the risks with the procedure and all. So it's your duty. The attending physician is always ethically on duty to obtain the patient's informed consent. So the nurse or the other providers could support, supplement or complement the doctor's specific information, but they are not on duty to provide, to gain informed consent. It's always the attending physician's duty. So consulted doctors, they need to gain informed consent on the procedures, on the treatment they are going to offer. Otherwise, it's still the attending doctor on duty. So there are exceptions where conditions, risks, or the side effects are not cannot be, or it's not mandatory to disclose some risks where the doctor is justified from keeping that information. The first one is called therapeutic privilege, where the doctor thinks the patient would benefit more from undergoing the procedure and would benefit quite less or could seriously be harmed or hurt from the information of a certain risk. So this is called therapeutic privilege. This could work in neurotic patients and all. So wherever there is a therapeutic privilege overriding, but these are very limited conditions. The other one is patient waiver's right to be informed. If patient chooses to stay ignorant, but he still is willing to sign the consent, then the doctor is not, could be exempted from prior disclosure of material risk. So the other one is doctrine of common knowledge. The doctor, if he assumes that the condition or the risk is something, for example, he's not supposed to tell a patient that he would have a wound after an operation. This is a doctrine of common knowledge. Or if the doctrine of prior knowledge, if the patient has undergone the procedure or a similar procedure priorly, and he had all the risks explained in the prior operation or treatment, the doctor could be exempted. The other one is in case of emergency, where the patient is incapable of giving valid consent or harm from failure to treat is imminent. This is again limited to few life-saving measures and procedures. So fitness or ability to consent and surrogate consenting. So we have said whoever is fit to give valid and informed consent. So those are the conditions discussed earlier. So in the cases you have to obtain consent, you should assume that everyone you meet is fit to consent. Do not assume that a patient or a client is not fit to consent. Your first assumption should be that it should be fit to consent. And also, you should not just read the conditions, the terms, the risks and all, and just make the patient sign. You should also make sure that the patient, the consenting party, has understood. So there are steps how to make sure that the patient or the surrogate has the fitness or the ability to consent. So the first one is to explain. The second one is to make the patient to repeat the information, and then to ascertain that the valid decision based on the information given, and then ensure consistency with the decision. So valid decision does not mean necessarily in favor of going into the treatment. For example, a doctor, when he presents as a patient himself, could refuse treatment. So if he's consistent with this decision, if he's aware of the risks of not being treated, but he still says that he doesn't want to go under the treatment, he doesn't want to go under the procedure, it's still a valid decision. You have informed him, you have made sure that he has understood, you have made sure that he knows the risks of not being treated causes on himself. It's not an emergency condition. And then the patient is also consistent with this decision. He consistently refuses. So then you should not assume that he's unfit. So always the decision is not to consent to treat. It could also be consent to refusal. So you just have to make sure that it's valid, it's based on the information, he just understands, and he's consistent with his decision. So in case where the patient is underage or incapacitated or has mental incapacity or is under the influence of alcohol or is comatose, so there could be conditions where surrogates could make the decision. At times you'd be faced with multiple surrogates, multiple sisters, or father and mother, and those surrogates could have a difference in opinion. Or those surrogates would have a difference or would fight as to whom should be enabled to consent. So in this case, you can take the case to legal courts, and the court would try to settle the condition in to whoever is legally allowed to consent in favor of the patient. So wherever a surrogate, once decided as a consenting surrogate, makes a decision that would harm the patient and the doctor is aware of this fact, still the doctor can further the condition to the court, since the decision of the surrogate, the consent of the surrogate is not beneficial to the patient. And since ethics is all about the patient, the doctor can ask for the court to waiver the decision of the surrogate and to be beneficial to the patient. There is also a condition where the doctor can consent in favor of the patient, where other surrogates are not available. They appear careless, they appear emotionally uninvolved, so the doctor can surrogate as a consenting party. So consent is always the major condition where most appeals of unethical conduct are made under. So what's your proof? It's always documentation. Document whatever consent you have obtained in clear terms, in explicit terms, and do not assume that the patient would know, except few conditions. Do not assume the patient would not be able to comprehend. So whatever, explicitly explain አድርጉ and explicitly document አድርጉ. And don't exaggerate prognosis, don't promise cure. So consent in case of victims and assailants, victims should always consent. There is no examination of the victim where he or she does not consent. But for assailants, the law of the state and law of the medical council are different. So these are different from country to country. So if you go for our country, even in criminal matters, in civil suits, an assailant can refuse an examination. But the consequence is the court would take the consideration that he is probably the assailant. So he runs that risk. In some countries, whoever is claimed as an assailant cannot consent. In some countries, can refuse. So the last concept, one before the last is consultation. This is the condition, duty of the medical practitioner in consultations. It's always important that necessary consultations are not delayed and unnecessary consultations should be avoided. So how do someone accuse you of unnecessary consultation? What should you do? You should always try to make your consultations justifiable and that it were in the patient's interest. It's very difficult to call consultations unnecessary, but you should keep in mind that your consultations are justifiable and in the patient's interest in case. So consulted physician, you should make sure when you're there at a consultant capacity, you're not taking over the case. The patient is still under the care of the attending physician. You're just there to be consulted. If the consulted physician is to make a statement, it should be in the presence of the attending physician. Attending physician, even after consultation, if posed with conditions, can change course of treatment. So it's up to the attending physician to decide at the moment. But later on, he should explain the reason for the consultant physician or for the consulted physician, the reason why he changed course of treatment. Difference of opinion should be communicated. It shouldn't be kept a secret. So this is what the attending physician says. This is what the consulted physician thinks. Or if you have multiple consultants, you should explain. This is what one says, this is what the other says. And the patient should be allowed for a discussion with all the consultants. So attending physicians has the right to prescribe medication at any time, but the consultant physician can only prescribe in case of emergency, or for the condition he's called as an expert for. So when a patient is referred to a specialist by an attending physician, it should be communicated to the referring specialist, to the referring physician in written form. And whenever you have made phone consultations, make sure you have documented it right away. And whenever you're consulting about a patient, keep your voices lower and do it in not very public areas. Consultant physician should not criticize the referring physicians. So whatever is the opinion, it should be discussed with the referring physician. So consultant physicians can collect fees for his service. They're allowed. It's not mandatory that it's included in the general medical fees. The consultant physician can ask for his own fee, but he should inform the patient pre-service before rendering the service. So whenever as a doctor, another specialist or another doctor is to give second opinions or second looks, you have the right, as an attending physician, you have the right to be there when your patients are being evaluated. So the last concept is duties of a patient. Patients have also duties. Since they are also entering into a contract with the physician, they have duties. So the contract could be breached from either sides, from the doctor's side or from the patient's side. So what are the duties of a patient? He must divulge all necessary information to help the physician make the proper diagnosis and treatment. So if you're not informed, and if it's not something that you're supposed to readily ask, you cannot be accused of making the wrong diagnosis. We'll see an example on the next slide. The other one is he must cooperate with the practitioner in regard to recommended investigations and procedures. If he omits such recommended investigations and procedures, he should discuss it and he should inform you. You're not supposed to discover that later on or from indirect sources. So he also must carry out instructions regarding medications, diets, exercises, and he should also show up for follow-up appointments. He also is supposed to pay the practitioner for his service. So this is one of the conditions. If the patient is not paying the service, the physician can discontinue to treat. So usually failure on the side of the patient to execute his duty comes to the rescue of the physician when accused for negligence or misconduct. So this is a case where there was a failure by the patient to fulfill duty. So a patient died from ruptured ectopic pregnancy. That was discovered later, but she told the physician that she had no intercourse and there was no chance of her being pregnant since she has been a relative celibate since her last child was born. Maybe that was a year ago or whatever. So the physician went on diagnosing that her condition was unrelated to pregnancy, but unfortunately she died because of ectopic pregnancy. So the court or the medical council ruled out the claims of the relatives that the physician misdiagnosed and killed their relative. So this would be the end.
All right. Thank you so much, Doctor.
I'm sorry, I took a lot of time.
Yeah, it's
Sorry,
he's
very
talking.
vast topic.
Yeah, no, it's okay. I think our participants have enjoyed the session. It was a really vast topic. That's why it takes like 78 slides. So I'm sorry on behalf of us for trying to make you talk fast or go through the slides really fast. It's
it's
because,
fine.
yeah.
The topic I picked up, so I take my share for the
Yeah.
condition.
Yeah, so at the end, like, thank you so much for again giving such a huge amount of your time for us to give this amazing lecture. And we thank you on behalf of our participants and on behalf of Blue Health. And we hope to see you in another session. Thank you so much again, Doctor.
Yeah, my pleasure. Thank you for having me. And
All right.
thank you for your time to everyone from the participants.